would like to invite the first speaker. We have a very exciting session this morning. We have 2 prize winners in it, so we are very honored to be here as chairs. Professor Hagen is coming from Scotland, still a part of the UK, I understand, and it's a multi-center randomized controlled trial of a pelvic floor muscle training intervention for the prevention of pelvic organ prolapse.
Well, thank you, and on behalf of the team, I would like to thank you for the opportunity to share the results of the PrevProl trial, and we really gratefully acknowledge the funding we received from the Wellbeing of Women charity to undertake this work. I have no conflicts of interest to declare. So it's been hypothesised that pelvic floor muscle training could prevent prolapse from developing through the mechanism of increasing muscle hypertrophy and functional recruitment of the muscles to support the pelvic organs. Thus, this randomised control trial aimed to establish whether pelvic floor muscle training could prevent the symptoms of prolapse developing and also prevent the need for treatment of prolapse. To summarise how this trial came about, in 1993 and 94, 8,000 women from Dunedin, Birmingham and Aberdeen were sent questionnaires 3 months postnatally to ask about postnatal urinary incontinence. From there on, the prolonged cohort of women were followed up in 2000 and then again in 2006. And in 2006, women were asked if they would like to come for a POP-Q assessment. In 2010, we identified the 1,200 women from Prolong who said they would have a POP-Q assessment, and we targeted those for recruitment into the PrevProl trial, and we aimed to randomise 400 women. So women who had not sought treatment for prolapse, but who did have some evidence of vaginal laxity, were eligible for the trial. Women who were eligible and consented were randomised to one of 2 groups. On the left, the intervention group were offered 5 appointments with a specialist physiotherapist where they had pelvic floor muscle training and lifestyle advice. The women were also offered, as a follow-up, a maintenance intervention where they were offered 2 blocks of Pilates-based classes which focused on pelvic floor muscle training run by specialist physiotherapists. They were also offered an annual review appointment with a specialist physiotherapist to look at the pelvic floor and how they were getting on with exercise. In the control group on the right, they had no contact with a health professional, and they were sent only a lifestyle advice sheet which gave information about how to decrease their intra-abdominal pressure. Both groups were followed up at 1 year and 2 years with postal questionnaire. Among the outcome measures that we used were the POP-SS symptom score, which was our primary outcome measure. And you can see on the right-hand side, this included 7 symptoms, which were summed to give a score of between 0 and 28, with higher scores indicating more symptoms, more frequency. We also asked women about the uptake of any prolapse treatment. We asked them about their urine, bowel and sexual symptoms. We asked about their pelvic floor muscle exercise practice, and also about any perceived health benefits they'd had from the study. So amongst the 485 women who we had POP-Q data for and who were interested in taking part, 407 were randomised. We had 1 post-randomisation exclusion in both groups, so we had 206 in the intervention group and 199 in the control group. On the left-hand side, you can see the uptake of the intervention in terms of the number or the percentage of women who attended the appointments, the one-to-one appointments, the blocks of classes, and the attendance at the 1 year and the 2 year follow-up appointments for review. You can also see the follow-up response rates for the questionnaires were high in both groups. So women in the 2 groups at baseline were very similar in terms of age, parity, method of delivery, and the stage of their prolapse. And you can see here that 76% and 73% respectively in the 2 groups had stage 1 or stage 2 prolapse above the hymen. On to the results then. In the top table, you can see that the mean POP-SS score was lower in the intervention group compared to the control group at 2 years, and that the mean score had decreased over time in the intervention group, indicating less symptoms, but it had increased in the control group. In the lower table, you see the results of fitting our statistical model to these data. The effect size, which is highlighted there, shows the estimated difference in POP-SS between the two groups at 1 year and at 2 year was significantly different. There was a 1 point difference in the two groups. So if we break this down, in particular, the odds of having the symptom of something coming down at 2 years was significantly less in the intervention group compared to the control group, as was the odds of having to strain to empty the bladder. The intervention group women were 3 times more likely to have done pelvic floor muscle exercises in the last 4 weeks when they asked them at 2 years. In terms of urinary symptoms, the intervention group had a significantly lower ICIQ, urinary incontinence short form score at year 2. In terms of bowel symptoms, the prevalence of fecal urgency and fecal incontinence were not significantly different between the two groups, but interference due to general bowel symptoms was significantly less than the intervention group. There were no differences between the groups in terms of the sexual outcomes at 2 years. And in terms of perceived health benefits, the intervention group were more likely to report a health benefit from the study than those in the control group. Uptake of treatment of prolapse symptoms in the 2 years follow-up that we carried out was low in both groups, and there was no significant difference between the groups in the uptake. The cost of the intervention was £519. The SF12 questionnaires that the women completed were converted into utility scores for each woman, and the table shows the average scores for each group and time point. The higher the number, the better the utility. So the cost per quality adjusted life years varies substantially from £17,000 in year 1 to £52,000 in year 2. So we feel a longer term assessment is really needed to assess the true cost effectiveness once we see the impact of uptake of future treatment by these women in the longer term, and we have 3-year data just available and 5-year data is planned. So in conclusion, we found pelvic floor muscle training can be effective in preventing prolapse symptoms in a non-clinical population of women who had not sought treatment for prolapse previously. We also found evidence of a reduction in urinary incontinence in the women and interference due to bowel symptoms. There was no evidence of a differential uptake of prolapse treatment at this point at 2 years, and we need to look at cost effectiveness more fully in the longer term. We generated important information for clinicians and for women in terms of the avoidance of future prolapse. Thank you.
Thank you very much. This paper is open for discussion.
Morning.
Good morning.
Good morning. Peter. Is it on? It's not
on.
Yeah, it's on. Peter is here from Utrecht in Netherlands. Good morning. A wonderful study and wonderful presented with good data. I have one question about the detail in your table, and I have one thing to speculate about if many arise. In table 2, some patients go to the GP and some other. But what's the consequence of those lines? What happened with those ladies? If they go to GP, they do not get a pessary, they do not get surgery, they not get a referral. What did they get? Or other? What's other in the table?
Probably some form of
herbal medicine. The other question is, I have good news for you. I have 200 ladies, inactive for 25 years, smoking and coughing, obstipated and overweighted. So I send them to you. They are 50 years of age. What can they expect? The same results?
Well, these were, I would say, these women are not completely typical of a general population, because obviously they have been taking part in our research for some time, so they are probably more motivated to do the exercises. Although, as you saw from the table, the uptake of things like the classes and the follow-up review appointments wasn't high, so there was adherence issues there. But I think I take your point that you might expect lower uptake in your general population.
You will need more money for that, ladies.
Yes.
For my ladies. Thank you.
Okay.
Thank you. I think it's an excellent study. Were the changes you observed meaningful to the women?
Yeah. This is a really important issue, and I think one that we're still trying to get our heads around. We looked at the minimal clinically important difference in the POP SS ourselves and found that 1.5 was meaningful for women, although we had looked at that in different populations, so they were women who had already presented with problems with prolapse. So I think we're not sure what a meaningful might mean for this group of women. The difference of 1 in the score, actually behind that, when you look at the decrease in the prevalence of some of the symptoms, I've taken a note here. So for example, that feeling of something coming down, at 2 years this had reduced to 17% in the intervention group compared to 29% in the control group, and similarly with the straining to empty, 27% versus 40%. So from my mind, I think that these seem like real changes.
Hi, congratulations for your presentation here. I'm Fabiana from Brazil. Could you explain a little bit more about how this Pilates-based exercise were taught, and how did you control that they were doing this or not during these 2 years?
So the physiotherapists we involved in the study were specifically trained. We sent them for training in Pilates, delivery of Pilates, and some already had expertise in that area. And then we developed the training round about that to ensure that there was a high content of focus on the pelvic floor muscle training. So that's the way we standardised the teaching that the women would have.
Did you have a protocol?
Yes,
oh,
yes.
Okay.
Very detailed.
The DVD had a protocol.
Pardon?
You gave a DVD of Pilates or no?
A DVD?
Yeah, some instruction.
Yes, the women were given written instructions about the protocol, but we also used the Pelvic DVD because it was freely available, and we suggested that they might use that at home as well for use of exercising at home.
Thank you.
It's time for a question there.
I have a question. Hi, Cora Hewitt from the United States. And my question is, in Pilates, I'm a Pilates instructor and IDEA certified and fitness and things of that nature. Some Pilates instructors do not instruct pelvic floor muscles engaging with the other deep intrinsic muscles. It's all the transverse abdominis, or as well as then limb movement going from short lever arm to longer lever arm. Did your instructors, who were physical therapists, did they state engage the pelvic floor, then the transverse abdominis, and combined with proper breathing patterns, move the limbs?
I don't know the level of detail that you're asking about there, but what I do know is that the physiotherapists were the same physiotherapists who were teaching the women the one-to-one pelvic floor muscle training, so I would suspect very much that the content of what they were teaching was based on that.
Yes.
I'm looking at my colleague, Doreen. She's nodding.
Good. Because you can't assume the Pilates instruction will have that component within it.
Okay. Thank you.
Okay, thank you very much, Professor Hagen.